today is the day of the commemorative day for the enactment of the Intractable Disease Law. And then 10 years ago, the May 23rd, that the Act on the Medical Care for the Patients with Intractable Diseases were enacted, and then which was a very major topic in policy making. And I guess various activities and the measures have progressed in the past 10 years, giving the significant good impacts on patients and families. Meanwhile, the policies cannot solve all problems. I fully understand the many new issues are rising in these 10 years. So we are also very much aware of that new issues coming up. I hope that we will have the good discussions on measures for Nambyo from the viewpoints of patients and citizens, looking ahead to the next 10 years and beyond, while reflecting on the achievements of the past 10 years. Now, let me introduce briefly our organization. Health and Global Policy Institute, abbreviated as HGPI in English, a non-profit independent private think tank which was founded in 2004. So that twice as long, the 20 years have passed since our establishment, twice as long as the Intractable Disease Act. So that we created the new logo to commemorate 20 years from the establishment. So far that HGPI is taking actions on various issues, including infectious diseases such as AMR and the vaccines, non-communicable diseases like dementia, mental health, obesity, and the renal disease. Recently, HGPI is also working to improve women's health, children's health, and the planetary health, which are regarded as healthcare and the society themes. That HGPI receives grants from corporations and the foundations and pursues as lean management as possible. The Institute seeks to get support from multiple corporations on one program, as we do today, to guarantee neutrality. And the HGPI members have diverse specialties and backgrounds, like myself, as an expert of the political and administrative science. Therefore, we are able to provide policy options and engage in advocacy activities from diverse viewpoints. In fact, that HGPI organizes the Intractable Disease Program for the first time. Since the mission of the Institute is realize health policies for citizens by citizens, we have had many chances to work with and listen to the voices of the patients and the stakeholders of the Nambyo or intractable, rare, and long-term chronic diseases. And it is our great pleasure to hold this symposium in the commemorative year, 10 years from the Nambyo Act enactment and 20 years from the birth of the HGPI. Thank you very much once again for your attendance and the support. So we'd like to say once again thank you so much for attendance and your support. And then finally, that I'd like to give you some logistic information. You can get the permission you can get the presentation materials thanks to the permission of the speakers by scanning QR code on the back cover of the leaflet. Zoom participants will also be able to obtain them from the QR code on the last page of the leaflet, and that will be shared later. And that some of the relevant materials and the proposals are also included in the file. Now it's time, so let us begin that Nambyo Day Symposium, Future Measures for Institute Intractable Diseases from the Perspectives of Patients and Citizens, hosted by HGPI. First of all, the speaker for today is the Kunio Tsuji, the Standing Director of Japan Patients Association, who contributed greatly to enactment of the Nambyo Act. So that Mr. Tsuji gives opening remarks from the perspective of patients and citizens. So Mr. Tsuji, the floor is yours. Thank you very much, and good afternoon, everyone. So thank you very much for hosting the Nambyo Measures Project to commemorate the Nambyo Day. Thank you very much for hosting this symposium. So the intractable diseases or chronic diseases, the patient groups, there are about 100 different groups covering the adults and the pediatric diseases. And the Japan Patients Association is the name of that association and working as the standing director. And our organization, JPA, was established in 2014 when the Nambyo Act was enacted on the May 23rd in 2014. So our organization was also registered on that day. So that it's been 10 years from the enactment of the law. So right now, the number of the Nambyo patients, so there is a government system of the designation of those diseases, and those who have some the financial support for the co-payment, about a little more than the 1 million. And then for the pediatric chronic, the specified disease patients accounts for about 100,000. So that about 1 out of the 100 people, or including the families, 1 out of 40 people have the relevant diseases. So what about the situation in your workplace? You don't know very much about that, or that you know someone using the help mark. So thanks to the progress of the research and the treatment, as introduced before, that they go to the hospital on a regular basis, and then they get some the drug therapy, so that they're enjoying the quite healthy life, and that they keep working just like the healthy colleagues. So that's a great advancement and a development thanks to the research. But at the same time, some people do not talk about their diseases in their workplaces. So they can work all right now, or no need to talk about their diseases in some cases, but the relapse or the recurrence is one of the problems of these kind of diseases. So that some people are facing a difficulty in continuing their work. And the people who have the registration certificate, although they are designated as the holder of those diseases, but about 70% of them do not hold the booklet or the certificate, so they tend to hide about their diseases, and so they are facing some difficulties and problems. So that in their health checkup conducted by the school and the workplaces, so the Ministry of Health try to encourage them to get that enough support, the medical support, and by disclosing the diseases. And I talked about work. And apart from that, there are some issues to provide the sufficient medical care, and also that there are some disparities among the different communities in the support system for them. And also they have some of the school problems, transition problems, and also the revenue, the financial side, that those people cannot enter the support program for the disabled support programs. So the Nambyo Act was enacted under the environmental diversity, and it is the likelihood is quite low, but it's quite common for the general public to develop that kind of diseases. So that's the background of the enactment of the Act, and then the promotion of the research and healthcare, and also the support programs, and then not only for the policies for the healthcare programs, but there are some social issues surrounding the patients. The HGPI have been giving lots of the proposals, and then the Nambyo is one of them, their programs. We have a very big expectation of that on their projects, and we are the people that involved in that, the Nambyo, and also that we have a big expectation for the people who are engaged in the healthcare to pay more attention and develop the treatment. And your neighbor can be the patient of Nambyo. So that I sincerely hope the success of these projects as well as this symposium today. So thank you very much again.
Thank you very much, Mr. Tsuji, for your wonderful remarks. Now, we'd like to move on to the presentations. The first presentation, Presentation 1, titled The Past and Future of Measures for Intractable Diseases from the Viewpoint of Civil Society. We have present from NPC, ASRID, Ms. Yukiko Nishimura. This is Nishimura speaking. Thank you very much. Hello, everyone. So today, my presentation is titled The Past and Future of Measures for Intractable Diseases from the Viewpoint of Civil Society. And there will be a full presentation following me. So I'd like to first give the presentation. It will be the overview on the intractable disease measures here in Japan. And I come from ASLID. This is the name of my organization. It's an advocacy service for rare and intractable diseases, multi-stakeholders in Japan. So we are not the stakeholders, but actually representing stakeholders, and we have been active for about 10 years. So we are at the same age as the Act for Nambyo. So let's look at this number together. As Mr. Tsuji mentioned earlier, this year, this is the 10th anniversary since the enactment of Act of Nambyo. And some of you may not be familiar with this number 42. So for intractable disease patients and families, this number is more impactful because this is in 1972, the outline of intractable disease control measures was established. So it took 42 years for the enactment of the act since the outline of intractable disease control measures was established. So this is the oldest in the world for the outline of intractable diseases. And after 40 years or more, the Act on Nambyo was enacted in 1972. Nambyo, intractable diseases meant it's a rare disease with a small number, and it was a very difficult disease. And after 50 years or so, this name Nambyo, the definition in 2014, there were 3 definitions that was given. The title of this is Intractable Diseases, but in overseas, we use the word Nambyo to represent intractable diseases and other diseases, and the interpreters will use the word Nambyo to cover all these diseases, because Nambyo means intractable diseases, rare diseases, and long-term chronic diseases. All these diseases are included in the word Nambyo. Of course, the relevant people wanted to have this enacted. In 1950s and 60s, the word Nambyo had been rooted here in Japan. So it's a socially used word. And after that definition was given, that is a flow of how Nambyo was established. So the image of what Nambyo brings and what is defined in the law, there is a little bit difference in people's understanding of what it means. However, we had COVID-19, so we had a 7-year review instead of the 5th-year review. And in 2022, there was revision of the intractable disease law, and the people from MHLW is going to define this later, but there are a number of measures that were taken. And with the Nambyo Act revision, we did evaluation of the relevant people. In the fall of last year, we had a Nambyo Forum, an event in which we had many people being involved to be evaluated. And what was evaluated as high was that we are now able to make applications reversely, retrospectively, and this was very surprising for people overseas that Japan was able to offer this kind of a system. We believe this is an excellent care that can be provided to people with Nambyo. And of course, if they are diagnosed as being severe, of course, the subsidy will be given right away. So you do not have to apply right away. And of course, the registration, the certification is given, and you can use that at your work offices and also at hospitals right away. But with just one revision, it is not as if we are going to cover everything. In the questionnaire that we were given, there were a number of issues that were raised for people with Nambio. Please go to our website and look at the details. With the Act of Nambio, of course, we are at the start line and we have started running. However, it is not complete yet. That is what we can gather from these issues being raised by people involved. And other than that, these are the situations that we see recently. So these issues will not be covered only by the Nambio area, the adjacent areas, and also coordination with the general public is needed in order to solve issues regarding Nambio. In June of last year, we wanted to create a society in which people will be able to access clinical studies. And of course, information regarding clinical studies, of course, the authority will give through the systems or databases information necessary. However, all those people who really want to have that information, who want that information to be utilized, whether it's being reaching those people and if the right knowledge is being provided, that is a question mark. For the patients, all the words used are very professional, so it was very difficult for them to understand. So with that, we tried to create a workshop in which we will be able to create a society in which people will be able to access those information related to clinical studies. So we will not only think from the perspective of patients, but we want to have discussion with all those people, stakeholders involved in clinical studies, so that we'll be able to raise our requests and issues. That is the design of this organization. And currently, this is a composition, constituents for the people who are involved in this organization. I think this is rare. Since 5 years ago, in oncology, we have been working with people, patients, and exchanging opinions. So oncology and, of course, Nambio has similar areas. And because our system is different, there are differences as well. So we wanted to confirm so that we want to advance together forward. And this organization is one of the fruitful outcome of these discussions. The member constituents, those are the patients who are involved with oncology, rare diseases, or intractable diseases. We have researchers and also doctors as well. And of course, we have researchers, etc. And of course, we have industry people, for example, PMD as well, involved. So since last year, Pharmaceutical Medical Association, there is an office there. So not only there, but we are gathering all the discussions from different stakeholders. So we'll be able to follow that information and access that information on individual basis. And of course, we have sent a recommendation or request to the authority. And this month, we will once again submit that request so that we'll be able to create a database in which people will be able to understand and people will be able to access. So this is something that we are all creating together. 10 years ago, it couldn't be thought of. People were looking at the different areas in a deep manner, but in the past 10 years, the situation has improved and has changed in a good sense. And of course, we like to introduce you to Rare Disease Day, RDD. So in Japan, we have translated as World Rare and Intractable Disease Day. So this is a social enlightenment activity related to rare diseases and one of the largest in the world. And we started participating here in Japan in 2010, and in February of 2024, we welcomed its 15th anniversary here in Japan. When it was started here in Japan, the patients became the organizers, and it was conducted in 30 locations here in Japan. And on Sunday, the past Sunday, the season just ended for this year, but now we have 75 locations nationwide which hold the RDD events. And the sponsors are all different, but this includes people working on oncology, chronic diseases, rare diseases, and also intractable diseases as well. And this event is in which we can have the opportunity to communicate with people in the civic society, and there are many different attributes. So we can speak to patients, HCPs, and not only that, but we have, for example, library being involved or one building being involved, and we have junior schools and senior high schools. These are general schools in which they don't have any diseases, but they do participate. And in Shimane, they have chosen RDD to work as a community, and they have involved university students as well. In other words, in the Nambyo area, it was very closed as a cycle. And it was very difficult for patients and families to communicate the information. But compared to 10 or 15 years ago, everybody wants people around the nation to understand, and they want to involve them so they can think together. This is where the event is coming from, and this is very important in that way. So rare disease include rare cancers and other diseases as well. Even if they're not designated as Nambyo, they can be involved. And for some diseases, which is very difficult to gather information, they provide information that is related to them in an accessible manner. So that is something that we want to continue to aim for. This is my last slide. In Nambyo, this kind of a wonderful symposium is now being held. So information for the patients, I think patients need to think for themselves what they can do. Of course, when we say patients, I think patients include family members as well. And of course, the information for the patients, how they utilized, how we can think together on the information is something that we can think about with the patients. And in the area of oncology, patients say that please not decide anything without involving us. I think it is the same with Nambyo. Nambyo is a wide-ranging concept. Therefore, we need to think that the targeted patients need to be involved, and in the discussion, they're not going to be at the center, but together as a member of the same team, they need to think together about the information that is available, and together they need to communicate so that they can take actions together. In the general society, in order to communicate this information, I think these are the initiatives that we need to be aware of. I'm sure the presentations to follow will going to be very informative because they are going to talk about different layers of activities and initiatives that is ongoing. Thank you very much for your attention. That is all from myself.
Thank you very much, Ms. Nishimura. That's very comprehensive, and also that the presentation is quite relevant to the following presentations as well. Thank you very much. So next speaker will be the person from the administrative side. So for the measures for the Nambyo in Japan is from the Ministry of Health, Labor and Welfare that we'd like to invite Mr. Yokota. So thank you very much. And hello, everyone. So my name is Yokota, and I'm working in the Nambyo Control Division, the Public Health Bureau, that Ministry of Health. So today I will talk about the measures for Nambyo in Japan. So I was wondering that what I should talk today. So it was introduced already, but there is a revision of the law, and from April this year, and also, so this revision does not cover everything, so we need to look ahead, the future, that the members of our department should keep thinking that what should be changed or what should be improved. So I cannot cover everything of that context today, but I'd like to pick up some highlights. First of all, this is the revised act. So 2 years ago, that there was a revision of the act. And then since the establishment of the Act, that was a major revision of the law happened. And then what is highlighted in red is quite difficult to read, but it's an improvement of the healthcare, and also that's the support enrichment of the recuperation. And also that's the database enrichment improvement was the firstly included. And then so we will consider that from the viewpoint of the citizens and the patients. So we administrative people do not create this only by ourselves, but that there is a council meeting at the Ministry of Health, and also for the pediatric specified diseases, there is another dedicated the council and the subcommittee. Not only the doctors and researchers, but the JPS are also involved. And then apart from the organizational people, but the people working in the work support and education are also participated. So to compile that proposals, so that I show this page covering that is the health expense assistance, and also that utilization of the healthcare related database and the information. So since the establishment of the law, that the major policies of the country was created, and then that this part didn't have the major revision, so that we haven't had the revision of the law and the review, so that was the first time for us to have the major revision to identify that direction of the country clearly. So there are many red color characters written here. It's quite hard to read, so please use this QR code to obtain the materials, so that there are the many revisions actually that conducted, so that the transition period healthcare support from the pediatric stage to adult stage. And it's from the citizens and the patients' point of view that is the relationship among the different councils were also mentioned here. So since this is Nambyo, so that pediatric chronic disease was also included, and then so the basic policy was formulated. So there was no rule to have the regular review. But now we have the rule to have the periodic review by every 5 years. So there are lots of advancement in the contents of the pediatric disease. So we created a guideline for the transition period healthcare, and also that we started a support system for them to start up their activities, so that it was enacted April this year. So as you may know, I'd like to cover some of the highlights of the revision. So as described in the beginning, so the start time of the healthcare expense subsidy, there was a major revision, so that, and so when they have the Nambyo, and then so if they specify the date of the classification, so when they get the certificate, so that when they get the medical certificate already, and then we can retrospectively go back to the date of that to start the submission for the healthcare expenses subsidy. So some people, it's quite hard for them to go out, and also takes time to get enough documents. So there are some inevitable reasons. So then we can wait longer than 1 month. So if there are some inevitable reasons, we can wait for the 3 months. So those inevitable reasons do not need to be written in details on the submission document, but there are the checkbox, so that it becomes easier for them to just only put the check mark. So the government tend to have the different decisions. It's not very convenient for the patients, but it's not more consolidated and unified, and then so speed up the administrative work. So those are the announcements made this time, so that the nationwide, so it started in the universal way, started in October last year. Although if they have the specified disease, and then the classification was severe, and then so they can get the support for the Nambyo. But from April 1st this year, that we started the program of the registration certificate. Although they have the designated the Nambyo, but condition was quite mild, so that if they want to get the job at the Hello Work Support Center, and then they need to bring the medical certificate issued by the doctor. But this time that they have the registration card, so something like the My Number card, and then if as long as they have the one My Number card, and then that can be used as a certificate, they are having the Nambyo, so they don't need to bring the other documents. So some people wants to get the paper document. So upon request, it's still possible to issue those paper certificate. Although the condition is quite mild, but they can show that they have the designated disease.
また今回なんて言いますか、患者さん
And
市民視点ということで、
this time that from the patient and the citizen point of view was regarded as important aspect, so that to strengthen the support system, so that there is the council, and we didn't have any the legal the support for those council for the chronic disease for the pediatrics. So not separately for the pediatric chronic disease and then Nambyo disease, but without having the border of that, it's important to give them the support in their community. So it is something related to the pediatric chronic disease. So it is to support their independent life. So that it was summarized on the right side, but the recuperation support and also the exchange of information among parents, and then the work support and the study support are also important. So those are done as a voluntary projects whenever necessary, but thanks to the revision of the law, so that they have raised to the importance to higher level. So that's why it is that's the project they need to do whenever necessary, not only the voluntary, so that it was clearly described on the law. And the next part is the database, not only to support their life, but also that how we can develop the drug to cure their diseases, and also for the analytical research for the researchers, the information and the data is necessary, so that if we can have the system to realize and good utilization of the database, it is beneficial for the researchers. So that we didn't have any legal rules for that, but we used to have the data for the designated disease, severe patient conditions, but not only that, we can gather the mild condition information as well, so that we can have the better view of the entire course of the disease development from mild to severe. So it says researchers. So the researchers, the scholars, are the only people who can get access to those databases. But now, thanks to the revision of the law, that private company people have access to that database from April this year. For example, the pharmaceutical companies, how they can utilize this database. So on the top part, it is more of the academic activities. But when they treat patients, so what kind of patients in how many? So the pharmaceutical companies want to get that information, but they didn't have access to that. So if there's a database of that kind, and then it is quite convenient for them to get the enough information, so that at the age of the 80 or 20, and then this pediatric chronic, the patients transit to the adult phase, so that sometimes that there's a transition of the name of the disease and how to get care. So we'd like to put all together into the database from April this year, so that the act was revised and it was enacted. And then I'd like to talk more about the future, so that we call it the healthcare DX, and it's becoming a common word. By utilizing the power of the digital information should be beneficial for the pharmaceutical companies and then all the stakeholders. And we need to make it accessible and easier to use. And then we created this process chart as a government. So the June last year, we decided on that, and then we started our full-scale activities. So the My Number card healthcare insurance is the hot topic. And in addition to that, it's the third from the top. So not only the hospitals, but it's a pharmacy, but also that local communities can have a good partnership, and also that is the healthcare, the service fee digitalization is another aspect. So with the utilization of the My Number card that we started this program, that is a PMH, the patients who need to get the expense healthcare expense subsidy, they need to show that there's some of the documents such as the registration certificate and then medical certificate and some booklet to get that financial support. But this time, this My Number card and the health insurance card are joint consolidated into one. So still, they need to bring that this registration card certificate and the booklet. But we want to change that as long as they can show that My Number card only, and then they can get all enough necessary support. And what is highlighted in the blue, so in the local community, government, and then they can input the information to the PMH, and then so that is the recipient ID certificate is issued, and then so they can get the certificate as paper, but this the residents in that the local community can present the My Number card only. And then, so if the city office people can check that that person is a holder of the certificate and then have the Nambio disease. So as long as they can show that My Number card alone, they don't need to bring that is the paper-based documents and the certificates. So as the citizens, so they don't need to bring the paper documents or the recipient card. Sometimes they lose those or they just forget to bring those. So sometimes they need to visit the hospital again. But with the new system that they don't need to do that anymore. And the local community can get the accurate information by checking that card. Sometimes that the hospitals input the same information again manually. Sometimes there are the typing errors and so forth. But now that the recipient certificate information is linked instantly so that it is shown automatically on the PC screen. So that is the people who are involved in that service can check all the necessary information accurately. So without making some the typing errors, transcription errors, so that the manual work will be eliminated. And then, so from last fiscal year, so we started some of the trials in some areas, although the scale is quite small. So, but we continue this trial project this year. So I have been talking about the recipient certificate, but also the vaccination and also the mother and the children health checkup. So not only for the Nambio patients, sometimes they get vaccinated, and then some people get is the pediatric health expense subsidy. And so not only the Nambio, but they are getting the different kinds of the subsidy. So they need to bring that this the Nambio recipient card and the pediatric disease card. So they need to show the multiple certificates. But now they can bring only the My Number card to get all the necessary financial support. And then health checkup, sometimes they get that. And then sometimes they can input the information from the smartphone, or they can show that My Number card so that they can get all necessary healthcare services, vaccination, and then financial support for the healthcare co-payment. So we started in some the cities as a trial project in these 16 local communities, so that we increase the number of the local municipalities, and we would like to increase the size of that, covering the prefectures, the Ichinomiya city of the Aichi prefectures, that they started a project for the pediatric chronic disease, for the healthcare expense subsidy, so that some of them are covered by the national government, and also that each prefecture has their own program to give the financial support. But all of those subsidy and the check of the qualification can be done with the My Number card. And then another one is the DX for the healthcare service fee program. So there are many elements here, but it's the payment, the administrative work should be reduced. And in the center, there is PMH, and then the local municipalities and the countries have the different systems. So when they get the treatment at hospital, sometimes that is a calculation can differ. They don't have a uniform formula. So first of all, that as a country that they need to have the common module, so they can use that the integrated number and the integrated way of the calculation, so that as one, so that the hospital can get the result of the calculation instantly. And at the bottom of this page, so the over the border of the multiple healthcare institute, and then they can get the calculation in the same way, and they need to bring the paper document to get the subsidy, so that they don't need to pay anything for the co-payment. But if they go to the different hospitals, now the system is linked so that the patients do not need to show the certificate at each time. Apart from that, so the drug discovery, so we have the working group at the Ministry of Health for the secondary use of the healthcare information. So the Nambyo database or the pediatric chronic disease database, such as NDB or the nursing care DB. So they are all kinds of database held by the Japanese government. And then that database information should be utilized for the development of the effective treatment and the new drug. The system started April this year, so that those data are anonymous. So if we obtain those data, we change them into the anonymous way so that we cannot get any specific patient's name or disease name. But there are some data very specific to that patient, but those are blinded and anonymized. So it's difficult to provide the raw data as they are, but it's a researchers, the drug company wants to know more about that. They want to obtain some specific information for their research work. So that's why. So we are trying to start the pseudonym system instead of anonymous system. For example, in the very middle, so such as height or body weight, if it's higher than the 2 meters or the heavier than 150 kilograms, and then we can narrow down the scope so that it become easier to specify the particular person. But it's the outlier test results can be effective and usable for the drug research. And then for the consolidated analysis can become possible thanks to the pseudonym system. So that it is beneficial for that is the development of the new drug and the medical device, and also the adverse events and adverse effects information can be utilized as well. So not only for the Nambyo, but we are discussing that what is a good way for the secondary utilization of the healthcare database information, so that pseudonym and anonymous processing is quite difficult to understand, but so you can get the material later on by reading the QR code. But to make the long story short, the pharmaceutical companies and the researchers can have a better access, and it's easier for them to continue their research, as well as protecting the privacy. So we are trying to find a good way to realize both. So it is very brief, but those are the activities we are involved in. So we cannot solve all the problems at once, but a distant revision cannot solve every problem. So that gradually, step by step, that we are promoting our activities and work. So I would like to wait for a little while for the better system. So I'd like to get your understanding and the cooperation. Thank you so much for your kind attention and support.
Thank you very much, Mr. Yokota. So thank you for talking about the measures that is ongoing at the Ministry of Health and talk about the outlook for the future as well. Mr. Yokota mentioned that when it comes to Nambyo, of course, research is a very important aspect. Next, presentation 3 We have Mr. Nakashima from AMED to talk about current initiatives in intractable diseases from AMED. Thank you. My name is Nakashima from AMED. So thank you so much for holding this event or symposium on Nambyo Day today. So I'm from Japan Agency for Medical Research and Development, AMED, and I'm in charge of the Nambyo area. So this is Nakashima, working on practical application research project for intractable diseases. So what is the situation of Nambyo research and its support? And that is what I want to talk about today. So the name AMED, some of you may have heard it, some for the first time. So let me introduce you to AMED to start with. So AMED was established later than the enactment of Nambyo Day. And of course, it was established in 2015 April. AMED is established to promote R&D in the medical field from basic research to practical application to facilitate smooth practical application of research results and to improve the environment for R&D in the medical field in a comprehensive and effective manner based on a plan for promoting R&D in the medical field. And of course, the bottom left, this is when the actual signatories were introduced at the establishment. And next year, we are going to welcome its 10th anniversary. And the president at the moment is Mr. Mishima. So this is looking at the outline of AMIT. Of course, we have been working on the research and development of the Health and also Medical Strategy Promotion Act, which was enacted in 2014. And we are like the control tower for research and diseases in the medical field. And of course, Minister of Health, Labor and Welfare have been working on clinical studies and other trials, and Ministry of Education on other areas. So with AMED, all the medical research and development are now under the control of AMED. So from research to clinical, this is what we are bridging and making it very efficient. And globally, we are now able to have a system in which quality research can be conducted here in Japan. This is the most updated. The second phase of AMED organization is shown on this slide. So this is a midterm plan for the health and also medical strategy. On the bottom left middle, we have 6 integrated projects, and we had reorganized the organization. From the top, a pharmaceutical project, a medical devices project, and also regenerative and also cell therapy projects. These are pharmaceutical or devices or other therapy projects that is provided to patients. That is how it is classified. And at the bottom, we have a genome and data infrastructure project. And beneath it, we have the disease basic research project. For example, pathology will be analyzed so that we can start with this project in order to provide therapy. And at the bottom, we have sheath development and also research infrastructure project. So the bridging organization or core hospitals is where we are going to develop these so they can be linked to research and infrastructure projects in other areas. And on the horizontal axis, we will find cancer and intractable diseases like Nambyo. These are the societal issues that we need to work on. So these are the 7 axes in which we are working on the researches. If there are any Nambyo consultation to AMED, we are going to consult with the coordinator, and the pharmaceutical project and also medical devices and regenerative and cell therapy, genome and disease. These are the 5 projects that will be involved in giving the responses. Are we going to provide pharmaceutical to the patients or medical device? Or are we going to support by giving different therapies, including cell therapy? So through the 5 projects, we try to find the response that is appropriate. And of course, we have different directors in charge of the different areas. So we are going to call them Nambyo and also treatment projects going forward, because it is a very long title. And this is looking at that project. What are the activities involved in that project is shown on the slide. And of course, we have been talking about designated Nambyo. They have 341 of them. And we are looking at reality, cause unknown, and efficient therapy not established, and also long-term effect on the life. These 4 requirements need to be satisfied so that it can be designated as a Nambyo. And there are 8,000 or more such Nambyos that is applicable, and we are going to support the diseases that meet those 4 conditions. So there are 341 Nambyo, but in addition, we are supporting 8,000 other diseases, so it can be led to different research and development in other areas. Of course, we need to look at pathology and also etiology, and we are going to have a narrower target so that seeds can be developed and clinical studies can be conducted. And we are going to give it to the pharmaceutical companies so that it can be launched in the future. At the Ministry of Health, we have the policy research group in which, as Nishimura-san mentioned, it is very important that coordination is done. So the researchers need to coordinate together so that these steps can be achieved. I'm sorry this is a very busy slide, but as I mentioned, the Nambyo and also treatment projects are divided by phases on this slide. In the middle, you can find the basic research. So we need to have the targets being considered for research. So etiology will be analyzed here. So this is our basic research. And after 3 years of support, then we will move to the next steps if it is applicable. And we will go into etiology, and if we know where to be treated, then we need to explore the seeds available, and that is called step 0. And 3 years of support will be given. And then the candidates for development will be identified, and then we go into non-clinical dependent on GLP, and we look at the safety and whether efficacy can be expected. That is step 1. And in the 3 years, if we find no issues, if it can be stepped up, but then we will go to step 2, in which clinical trials can be conducted. Clinical POC will be acquired, and if efficacy is expected and if there are no issue with toxicity or side effects, then it can be offered to the pharmaceutical companies. And it was mentioned about the database earlier. The registry foundation will be established, and this can be used by different research groups. And of course, this foundation will be explained in detail using a different slide. They are undiagnosed diseases, which is very rare, and we support such diseases as well. And of course, when creating a guideline, we need to collect data. So evidence research is also supported by us, and every year, 200 projects are supported. This is done by public tender and other selection methods by different committees. And these are the characteristics of the projects that I was asked to explain. Of course, we have been supporting different projects, so it will include my personal opinion, but I have listed what we do. When we talk about the rare and intractable diseases, of course, the patient group is very, very slow. So as a business, it is very difficult to be established. So it is very difficult to get the support of the pharmaceutical companies. And of course, case accumulation is very difficult. So it is very difficult to collect the number of cases needed for approval. And of course, development difficulty is very high. And of course, etiology is not clear. Therefore, what is the disease that we can work on is sometimes very unclear. For hypertension or DM, hemoglobin A1C, the different evaluation items that we can look at. But for some of the diseases, these criteria is very difficult to identify. So we need to start from that for some of the diseases. And because it was not treated with different treatments, therefore there are many high unmet medical needs. For example, nucleic medicine or gene therapy, there are different technologies that can be contemplated by different researchers. So in other words, there are a lot of issues. How are we going to balance benefit and risk, efficacy, safety? This is something that we need to consider because these diseases have different evaluation when it comes to benefit and risks. And pharmaceutical companies can make the application, but we are basically supporting a lot of academia, the researchers in those areas who apply. And 2 years ago, we looked at the full requirements. For example, the movement of the companies, regulated science, science technology, and also the peripheral environment. And we did the macro and interview survey in each of the areas so that we can reflect them in the businesses. In order to solve some of the issues, we needed to make sure that we took the actions. As you can, at the bottom, the rare diseases and ultra-rare diseases, and sometimes it was difficult to work on them, but now we are asking the public application for them. And in order to make that possible, we are utilizing registries and RWD. And overseas, there are initiatives in which they support diseases with less than 50 patients. So we are trying to support that kind of a small-scale medicine as well. And this is looking at a registry. We are calling it Nambio Platform. So we are looking at the natural history, the real-world data. These can be utilized for research and development. So this is not only done by different groups, but this is a platform that all the researchers will be able to access and utilize. Not only AMED researchers, but Ministry of Health Research Group can also use this platform as well. And by using this platform, we are going to decide whether there is a significance for supporting that disease. And of course, pharmaceutical companies will also be able to use this as well. And when it comes to placebo and also the actual disease drug, of course, it will be difficult with a very limited number of patients. But we like to see that looking at the natural etiology of the diseases, all the patients who enter, if the number is limited, then we provide a study drug to such patients. And of course, PMDA is also involved in the system as well. So ERS is utilized. So it is very highly trustworthy. So we make sure that reproducibility is established and secured. And in the next steps, we are going to see within the research groups how we're going to use that for secondary treatments. And we are going to use the next 3 years to decide on how the pharmaceutical companies can be involved for the promotion of the secondary use of the information received or achieved. And IRAD is the initiative on rare and undiagnosed diseases. Patients may have symptoms, but they may go undiagnosed. They must go to different medical institutions. They do not know the cause. They cannot be diagnosed, and they cannot be treated. So we make sure that they are diagnosed, and we make sure that they refer to the expert, the specialist doctors. That is a global initiative of IRAD. And of course, after diagnosis, what is the treatment provided? That is what we think about, but they are diseases in which they go undiagnosed. So we need to make sure that the environment is secured so that undiagnosed patients will be able to go through a system in which they can be connected and provide data treatments. And of course, with AMED, we are looking at different success stories, and these are the recent areas in which we had seen very good success stories. And this is looking for muscular dystrophy, in which it was found here in Japan. It was approved, and this medication is now available to patients. And in 2022, there were two drugs that were approved. These are the same drug. However, the indication is different, and researchers involved were different as well. So it was an approved drug. Now, they had tried with the different basic data and tried it on intractable diseases, and they were proven to be effective. So drug repositioning was done with these drugs, and of course they were very successful. And this year we have had 3 approvals, and one is for genetic recombination drug for autoimmune pulmonary alveolar proteinosis, and also another one for athenuraminic acid, which was approved for distal myopathy, and other for refractory vascular tumors. So for ALS as well, the application filing was done for approval, and after 6 months, after the review, we hope that by summer we'll be able to have approval for that indication as well. So today, Mr. Nishimura attended this meeting and has come back from this meeting. This is our ERDRIC activity. This is a consortium. It's an international consortium for rare diseases, and AMED is an official member of this meeting. And of course, coordination is very important. Rare diseases, the number of patients is limited, data is limited, so international coordination is going to be very, very important. AMED is participating, and as you can see on the left, we make sure that diagnosis is improved, and of course, we will see new treatments available, and we come up and develop new evaluation methods. And as you can see, going forward, the diagnostic rate was 44% with the IRDEX efforts, so that undiagnosed patients had a better diagnosis rate going forward with the efforts. And with the AMED's projects, we hope that we'll be able to reinvigorate these efforts initiative we take with this consortium. And AMED in the NAMBIO projects that we conduct, once a year, we ask the 200 researchers to come together so that they can report on their successes. And this year, it will be held July 3rd. If you are not able to see it on the day, the information will be available on the website for 6 months or so. So I hope you'll be able to go to this. And on the left, this is a survey of the researchers who participated. And They wanted to gain the most updated information regarding research, and they wanted to know the status of the development of new therapies for specified diseases. So 75% of the people who participated in this reporting session said that session was very good. One of the participants, the daughter, had a designated disease of the heart, and the father came up with a movie to talk about those diseases. By not giving up, they said that the future became brighter. So the patient groups or the patients, I hope you'll be able to see this reporting sessions of these cases so that many of the research may be successful in a few years' time. And I hope you'll be able to support the researchers as well. And many pharmaceutical company representatives are here today, I believe. So we hope that you'll be able to find different seeds that is ongoing, and we hope that we will be able to get approval so that if you have consultations requests from the researchers, I hope you'll be able to support such researchers in these ways. So AMED is working on PPI, patient and public involvement, and in the Nambyo area, we believe it is very important. So all the researchers, we say that from the researcher stage, please consult the patient. That is what we request. And creating protocol is very important. And of course, patient survey, we believe is very important from that stage. And this is a promotion of AMED. There are many information through Twitter or Facebook that we communicate. So if you're interested, please look at all these information sources and find out more about AMED. Thank you very much for your attention. Yes, thank you very much, Mr. Nakashima. And thank you very much for talking about the outline of AMED, and thank you for also talking about the specifics. Thank you.
Next, I'd like to invite another speaker from the local government who plays an important role. And then measures for the Nambyo in Kanagawa Prefecture, and then that is for the one of the local community. And then Tsushima-san is a speaker, so that she has a work to do, so that she participate online. As introduced, so I'm working in the Kanagawa Prefecture, the Cancer and Disease Control Division, Healthcare and Medical Service Department, Health and Medical Service Bureau, Kanagawa Prefecture Government. So thank you very much for inviting me for the memorable day, the 10th anniversary. So I'd like to begin my talk using some slides. So at the Kanagawa Prefecture, measures for Nambyo. So let me introduce Kanagawa Prefecture first. So having about a 9 million population, so the 25.6%, and that's the ratio for the elderly people, and lower than the national average, but we are very sure that this aging will progress quite rapidly. So that including the Nambyo measures, but we always work hard to provide that's the healthcare system so that everyone can get the can have that healthy life without any concerns and getting the sufficient treatment. So let me talk first about the support system for the Nambyo patients. First of all, that's the healthcare system. So it is the nationwide system. So that this is the medical expense subsidy for those who satisfy some conditions to lower the burden of the co-payment. So that we provide financial support for part of the healthcare expenses for those who satisfy some criteria in Kanagawa. So in March 31st this year, so that around 23 million are designated. So apart from the government ordinance designated cities, altogether for the entire prefecture, around 60,000 people are designated. So that those are the designated diseases shown here. And then Let me talk about that is the consultation support system in Kanagawa Prefecture. We established that the Nambyo Consultation and Support Center, so that for the patients who live in the community in Kanagawa Prefecture. Sorry for that. So for those who live in the community, if they have something to they want to consult in their daily life, and we provide a consultation and support system. And we also provide a work support. In the Hakone Hospital since 2017, we contract this work to this Hakone Hospital and the independent administrative agency. And then, so the neurological, that the rare disease and the intractable disease are very much treated in this hospital. So they're very active in the treatment of those diseases. And also that it is managed jointly by the prefecture and the 3 cities, so that the people living in those cities and prefecture can go to the hospital to get consultation. And then for the last fiscal year for the Kanagawa Prefecture, 1,239 cases were the consultation, and mainly so that the various information for the recuperation life and also the introduction of the hospitals and the clinics. And then we're getting other consultation from the patients. And then the patients also can get consultation service in the nearby public health center. So the local community and also the bigger the area for the entire prefecture. So they are the 2 systems to provide the consultation service to the patients. So this page shows that the image of the patients who get the healthcare support, so that there's a patient at the center. On the left side, in Kanagawa Prefecture, there are 4 university hospitals working as a Nambyo Treatment Alliance hub. So if the patients want to get the specialized treatment, or sometimes they cannot get the sufficient treatment in the nearby hospital, so that the patients can go to those hospitals. And then the right side, there's another group of hospitals provide a Nambyo healthcare support. So there are the 8 different medical regions, and then the patients can go to the nearby hospital in their community. So there are 29 hospitals designated as the healthcare support hospital for Nambyo patients. And then at the bottom, there is their own clinics. They always go and get the primary care. So there are some of the clinics and the hospitals in the community, so they provide healthcare in cooperation. So between them that they exchange information, they support each other, and also that we provide some training courses so that they can get the updated information. And then the right bottom, and then this is the facility for the respite. The caregivers, if they request, there are some hospitals to accept them. There are 9 hospitals to accept caregivers for respite. So upon request from patients, the families can go to those respite hospitals. And then this is another slide just showing the image of the alliance. So patient at the center. And then so there is the hub hospital for the Nambyo treatment. There are 4 hospitals in Kanagawa Prefecture, so that they get the consultation for the medical treatment. And as I introduced on the right side, so the Nambyo Information, the Partnership Center, so that this is the Kanagawa Nambyo Consultation Support Center, mainly for the recuperation and then work support, and also to provide information regarding the hospitals inside Kanagawa Prefecture. So the hospitals, and then is the Alliance Center, and then provide information. So we support patients in those channels. And at the bottom, that public health center and then municipalities, they are closer to their patients, that they can get some administrative work and then to receive some documents and application, so that there is a link among those entities or cooperation. On the left side, for the specialized institutions such as the work support in particular, there are many cases of that, so that we introduce, they can go to the Hello Work or the industrial, that's the public health comprehensive support center, are providing the work support. So next, I'd like to talk about the roles of the each entity. So as written here, and then so please read the details later. And then the hub hospitals mainly provide the specialized care, and they provide that information regarding the advanced care and the specialized care. And also they provide the partnership and the support and provide education to the local hospitals. So those are all written and summarized on this page. And then the next page shows the list of hospitals in each that the healthcare region. So this year we newly added the 3 hospitals designated. So there are the support hospitals distributed all parts of the Kanagawa Prefecture. And then the page 7 summarizes the future challenges. So the Kanagawa Prefecture has the council for the Nambyo measures. So that those are the issues identified. And the first one is the pediatric Nambyo patients. So that it is important to provide a seamless health care. So that we need to provide a seamless consultation and the support services as well. So how we can improve our activities in that context. And the second one is that how we can share information and link information between the information center and the hub hospitals. Sometimes it is important to have the common understanding of issues or to find the new issues together. So we are discussing how we can do this partnership work more efficiently. So we are getting the different opinions and thoughts for that. And then I skip to number 5, that is the support of the number of patients at a time of disasters. So recently we are facing various disasters. So for the patients face those disaster situations in the communities, how we can support them. So we also have the discussion on that. So there are mainly 6 different challenges. And then what is written at the bottom tells that provide the healthcare seamlessly to the pediatric Nambyo patients. That's our important theme. And we need to construct the good system and under the good partnership among the different players, especially for the transition stage from pediatric to adults. And then this is one of the issues from patients when they become the older and then go transit to the adult phase, and that they face different life events, so that they need to get more support. And to provide that healthcare service, so the alliance among the different hospitals is not enough for the patient treatment. And then not all the chronic, the pediatric, the specified disease patients can smoothly transit to the designated Nambyo category. So that's the challenge. And it is important to share the understanding that there is a challenge of that kind. And then they transit from the pediatric stage to adult, so that we should have the closer partnership and information sharing. So let me talk a little more about the pediatric patients. So as written here, so I would like you to read that, and then I will move to the page 10. So the support their independence, and also in the transition period from pediatric to adult phase, we provide some specific support, especially that the healthcare service support. If the patients become adult, and then for them to get the appropriate care, we need to provide that one integrated support system. In Kanagawa Prefecture, we have the Nambyo, the consultation and support center in the same location. There is a healthcare support center for the transition period patients so that we dispatch information. So the transition period support center are now recognized gradually so that the number of the consultation has been increasing so that we organize that lecture session every year so that we can identify that there are issues and the challenges through those lecture sessions. So lastly, I'd like to introduce that the future image of the healthcare support at the time of the transition period. So there are the consultations we received, and that there are the challenges identified, and not only the partnership, but on the gradually we need to take actions and we need to provide the more profit and prompt the consultation to those patients in the transition period. Thank you very much for your kind attention.
Thank you so much for joining us despite your busy schedule, Ms. Tsushima. So this is our focus at the moment. The issue is transition medicine. That is an issue. Therefore, we asked Kanagawa Prefectural Government representative to talk to us about that. Next. We are going to talk about co-creating research with patients and citizens. This is presentation 5. It will be presented by Dr. Asashi Kogetsu. Thank you very much. Thank you very much. Hello, everyone from Osaka University. My name is Kogetsu. I am going to talk about co-creating research with patients and citizens. First of all, the research to be created with patient citizens. Let me give you the background to this first of all. Of course, with the advance in science and technology and advancement and sophistication of healthcare, of course, experts are leading medicine, and also there are limitations to medicine because we do not know whether we are reaching the patients. There may be a gap created between HCPs and patients. That is an issue that we're facing. And in the past 20 years, we are now talking about PPI, in which in medicine and healthcare, when it comes to practice of medicine and research of medicine, we need to make sure that patients are involved in the processes. That is becoming more widespread. And the background is that there may be some heightened activity with patients taking the ownership and also the nation understanding the promotion of such initiatives to be very important. There's an organization called Involve in UK, and they have come up with a definition of PPI, which is well known. Research being carried out with or by members of the public rather than to, about, or for them. That is a definition by Involve. So very briefly, I want to talk about the situation of PPI here in Japan. In 2008, in oncology, we have started involving patients and civil society. And in the early 2010s, we have had many citizens participate in research. Rooty Japan is what we sponsor. This is targeting rare disease patients, which they are involved in research. And this was established in 2014. And later in that decade, AMED and other national organizations have started promoting and putting into practice PPI. So here in Japan, it's been very active in the past 10 years. And this is what we have been sponsoring as a research office at our university. This is what we are involved in, and I want to introduce you to the common project shown top right. There is a link at the bottom, and this gives very detailed information about this project. So if you're not aware of this, I hope you'll be able to go to this link and see what is involved. So let me give you the background to this Commons project. Of course, when we come up with policy formation, of course, we need to have evidence. And with that evidence, policy will be formulated and put it into practice. And at the same time, in that process, the stakeholders need to be involved, and that significance is being recognized. In medicine and healthcare, of course, the priority should be set of research, and in that process, patients are involved. So prioritization means which kind of research should be taken up. So this is the most upstream of research, and patients are asked to be involved. There are many precedences. However, it is not as if all the information are reflected fully. So there is no establishment of the way in which patients' perspectives are reflected on the policies. So in 2008, we started the Commons project. So centered on rare diseases in medicine and healthcare, we are trying to create evidence that will be useful for policy formation. And for evidence creation, we are looking at the efficient way in which stakeholders can participate and coordinate. So last year in fall, international paper was published on this evidence. So I hope you'll be able to go and read this paper. So more than 10 patients were involved in this project, and they're involved in this paper as well. In the evidence creation commons project, patient family researchers and administrative experienced experts are working together so that they can create evidence creation. And as you can see, bottom right, there are 10 diseases that we have targeted, and 43 stakeholders were involved in this Commons project. And in this Commons project, there were 3 steps so that we will be able to prioritize. Step 1 is that rare disease patients' issues were first extracted. So as you can see, top left, we use post-its to come up with the identification of the issues faced by rare disease patients. And step 2 and onwards, the issues that were identified were now designated as research themes, and we try to prioritize them. We were not involved in prioritizing themselves, but in this project, step 2, we first came up with criteria to make the decision as to whether that research theme should be prioritized. And by using that criteria, we were able to set the priorities. So there were 2 steps involved. So more than 20 workshops were conducted in total, and we had opinions and ideas being reflected, so that we'll be able to revise the themes and discussion points. And of course, patients also were participated, and we had discussions, and we summarized the results, and patients were involved in recommendations and writing papers as well. And these are some of the issues that are faced by the rare disease patients. As you can see, delay in diagnosis, no treatments available. There are issues related to medicine, but the other issues related to life, family, society, recognition, awareness, connection, emotional, and information issues as well. So there are many wide-ranging issues that were recognized. And when at step 2, we decided and held discussions on the criteria. And there were 8 criteria that we decided to use in the workshop. The 3 highlighted as gray we decided that they were not to be utilized. So using the 5 criteria, we decided to do the prioritization. I'd like to take up the 2 top criteria for this purpose today. So the first is about the QOLs from different perspectives. Number 2 is to allow independence of the patients. So these are the criteria that we believe belong to the group in which it is very important for rare disease patients to be independent, and we are able to utilize these criteria to prioritize. And one is issues related to life. Number 2 is about medicine, for example, emotional and psychiatric issues. And number 3, the burden of going to hospital. So these were the most important decision criteria that we thought were very important research themes that we need to work on. So this is how we prioritize the research themes. And with those decisions, from our experience at Commons, we looked at the value of creating evidence. And number 1 is to create evidence that in coordination between the stakeholders. Of course, the issues, difficulties faced by rare disease patients are not met by the current and existing policies or research. So we need to reflect the stakeholders' perspective in order to prioritize those research themes. At the beginning, we did not imagine this, but on a reflective basis, it is very important that the platform of Commons had provided value. So participants were able to find out about different perspectives available, and they were able to see that they had grown themselves. And Commons became a platform in which they were able to have very deep discussions. And when we put the project into action, there were some issues that we had faced. From step 1 to 2, 2 to 3, there were a number of issues that we faced. And that purpose was not really understood by all the members participating. For example, in some of the specific research themes, we call them research questions, but it was very important that we add a step in which people understand what we're talking about. And we had a short lecture in which we talked about what research means to the researchers. And with these efforts, we were able to deepen the understanding of the participants. So the stakeholders come from different backgrounds, etc. So when they coordinate, it is very important to translate what we mean so that we will be able to fill the gap between understanding and knowledge. And to end, I'd like to talk about some of the recommendations that we were able to give. We wanted to make sure that to realize research or policies that reflect patients' perspective, we came up with 3 recommendations, as you can see here. Please use this QR code so that you'll be able to access the recommendations that we have come up with. Reference to the voices of the participants of the Commons project. This is a reference material in which you'll be able to see the voices, the actual opinions of the participants. So I think you will be very much interested in this. First recommendation, to promote research that leads to the alleviation and resolution of various burdens of patients and their families. That was the first recommendation given. There were 7 themes that I talked about today. I think this is one example of meeting this recommendation. Many of the research are already ongoing, but by involving the patients, we are able to come up with more effective research. And this is not widespread yet. Therefore, recommendation 2, promote patient-initiated research and activities. So patient-initiated research and activities to promote that, what do we really need to do? What kind of impact will it bring? That is not very clear yet. So recommendation 3 is to promote research on patient engagement. So these are the 3 recommendations that we have come up with through our project. That is all from myself. These are the people who were involved, so I'd like to thank all those people as well. Thank you very much for your attention.
Thank you very much, Dr. Koketsu, for the wonderful achievement. So now we'd like to begin the panel discussion. So please give us some time to change the layout. So it's time, the 4:30 sharp as scheduled. So using this 30 minutes, we'd like to have the panel discussion by inviting the speakers for today. So we'd like to have the panel discussion to conclude today's symposium. So that this is a symposium for the Nambyo Day, and then this is the first time for the HGPI to organize a seminar under this theme, so that we have had the discussions and with the experts, and then we listen to the voices of the various stakeholders. So there are some challenges to support the patients by providing enough the healthcare system, and also the welfare challenges, and also the social environment challenges. So there are quite diverse and a wide variety of challenges identified. So we spent about 2 hours for this symposium. In planning this symposium, so that there are the various activities conducted for this Nambyo arena, so that HGBI tries to provide some of the new values. And then, perspective of the patients and the citizens would be the good theme. So that we pick up that theme. So we, instead of pick up the one single theme, but we'd like to have a good look back of what we have achieved in the different perspectives. So the panelists today agreed with the policy to hold this seminar from the citizens and the patients' point of view. So in the presentation given today, there are the different challenges and themes related to Nambyo covered. So from now, I'd like to show this page. So there are 2 major themes for this panel discussion. So we are the HGPI that so we think that this is a very important theme for us to talk about the healthcare system, and then how quickly we can have the patients in the system, so that there is an issue of the diagnostics lag, so that we need to promote that early detecting of the diseases, and then when they notice the conditions and till the time of the final diagnosis, it takes time, so that once they are diagnosed finally, and then that's the start of the healthcare and the financial support. So that's the challenge we are facing. So in particular, that there are the needs of the patients and the citizens. So how we can capture those needs to be reflected in the healthcare-related policies. So for this topic, we'd like to hear your opinions. So first of all, the Otsubo-san, you didn't give the presentation today, so I'd like to ask Otsubo-san to give us some of the suggestions, and including your introduction. Good afternoon, everyone. So from the JSA, that JPA, that I'm the head of the administrative office of the association. My name is Otsubo. Thank you very much for holding the seminar and the symposium today. So I would like to say thank you again to everyone. So the diagnostic lag. So what's happening now? So today is Nambyo Day. So it's been 10 years since the enactment of the law. So from the January 1st of the following year, it's been 9 years and a half around since the enactment of the act. So there are 56 designated diseases at that time, but April this year, 3 added, so the 341 in total are designated as a disease. And then around 300 diseases are designated. And then we are seeing the progress of the researchers. And then the system to provide healthcare to patients. So there are the hospitals working as a hub for the Nambyo treatment, and that there are some the hospitals supporting them. So we are having the better system of the cooperation. And the IRED was another one, as Nakajima-san introduced, so that we are having the better systems. Nevertheless, although we are having the better systems, the Nambyo is regarded as rare disease. So the information and the knowledge are still limited. And although the same one single disease can develop all different kinds of symptoms, and then until they are finally diagnosed, it requires a very advanced and then the very specialized tests are needed. So we still have the problem of the diagnostic lag. In particular, in the smaller cities, the number of the specialists are limited. And although the disease is designated by the government, but it takes time to diagnose as such, so that during that time that patient's condition get deteriorated. So there are some gaps among the different communities between big cities and small cities. And then Monday this week, we had the time to give the appeal to the legislators and the Congress people, and that's the regular event. And then the diseases that not diagnosed yet, so that to identify the cause of the diseases and also the criteria for the diagnosis, and then to eliminate the gap between the different cities. So we got the 360,000 signatures to agree on our strategy, and then we sent that request to the government and delivered that to the Congress people, and then twice a year, and we include those requests, and also in the council meetings for the government, we give the proposals and requests. And then what is needed for the future? So there are the 341 designated diseases right now, but the pediatric diseases, 788 diseases are designated as a chronic pediatric disease. So that means that the portion of the designated disease is less than half. So that the pediatric, the chronic, the specified diseases, as long as those diseases satisfy the criteria, should be regarded as a designated diseases category as soon as possible. And apart from that, the digital the technology has been advancing, so we can utilize that, and also that we can promote the remote examination by doctors, and the genome treatment therapy is another thing that we need to promote. So Astrid Nishimura-san is one of the presenters today. That the October last year, so we jointly visited that is the Rare Disease Association in the United States. So the early detection, early diagnosis, and early treatment is still the big challenge in the U.S. So the primary doctors and the specialty the expert doctors should be linked online. So that's the activities started in the US. So that's the program that we can start in Japan. And the genome treatment, if it diagnosed early and then start treatment early, it can prevent that deterioration of the symptoms. And also the gene counseling, as a package should be provided to patients, and the personal information should be protected in a very strict way. So that's another important aspect. So that's about all from me. Thank you very much. So that is the uneven distribution of doctors among the different cities and towns. And you identified the current challenges very clearly. So Nishimura-san, do you have any comments? Thank you very much. So on the presentation material that the autumn last year, so there was a revision of the Nambyo Act, and then we tried to pick up the voices from patients and families. When we conduct those surveys, what is the biggest the voice from them? So that's the common question. We talked about N1, but is the voice is small, and then from the few patient, we cannot say they are not important. So we try not to disclose that what are the most common opinions. Rather than that, we try to capture all the different opinions and then investigate the details, and then we need to share those opinions to experts. Sometimes there's the budget constraints and also the priorities done by the administration, but it's the base information should be captured in everything. So we need to capture all the different voices. And it overlaps with the Otsubo-san's talk, but there is the discrepancy in the amount of information and the level of the medical treatment. So we need to have a good discussion on that. Otherwise, that the patients get left behind. And then the discrepancy for the medical care is that the rare disease is a kind of the niche, so that we don't have the big luncheon seminar done by the company in the big conferences. Rather than that, so they're the very highly specialized that only the expert doctors can get together. So they have the quite a minority type of the conferences. So it's quite hard for the general doctors to get exposed to the information. The opportunity is very much limited.
And also, if there are many departments involved clinically, so in those society meetings, they may take up that disease, but at those clinical departments, they may not be taken up. For example, one disease, we would like the ear doctors to understand or psychiatrists to understand first, but that kind of information is not disseminated at such society meetings to the experts. So how do we provide the information to the HCPs? And what are the training tools that can be created for the HCPs is something that we need to think about. And as for the gap of information, of course, pharmaceutical companies provide information, and that is very, very important. It needs to be accurately and timely, in a timely manner, be disseminated. The negative information, some companies refrain from providing that information. So I think we need to have a direct communication of the information from the patient's side. It is not done, so they feel frustrated. How regulatory system takes place going forward is going to be very important, not only with patient, but pharmaceutical companies, other stakeholders need to be involved so that we can think together so that accurate information, knowledge can be communicated to the society. I think that is going to be important going forward. Thank you very much. So in addition to what Mr. Otsubo said, how we are going to deal with the information, how we're going to communicate that information was mentioned by Mr. Nishimura. So we need to connect the voices of the patients. And as a researcher, you have been accumulating those information. So can you talk about what you have been doing in that area, Mr. Kogetsu, please? Yes, I talked about the Commons project earlier, and from what we have learned through that project, we can say is that, of course, I had shown you the maps, and when it comes to the rare disease patients, there are many issues that they face, but they are very widespread. So with the existing support system that we have for Nambyo, medical framework that is available now, they will not be able to cover all the issues that the patients face. So the research into those areas is not taking place at all, or they are not sufficient. So, what are the difficulties that patients face? And for such difficulties, what are the responses that we can come up with? That kind of research is also needed. May I continue? Yes, and from a different perspective, diagnostic lag was taken up. This is not my research area. However, in my research lab, Dr. Isono is doing a very important research. So let me introduce you to that research very briefly. Dr. Isono is looking at the HAE, which is a hereditary angioedema, and they had interviewed patients. And when they discussed why it took so long for them to be diagnosed, and one important matter that surfaced is that, of course, it may be a rare disease, it may be a nambio, and the process starts working when they realize that it is a nambio. But for them to realize it is nambio, it takes time. So how do we respond to that? I mean, the doctors look at patients in front of them. They need to realize that their patient they're looking at may be having nambio. I think that recognition is very, very important. Thank you very much. Yes, when it comes to nambio rare diseases, of course, that is the center of the discussion today. But to start with, whether it's a nambio, whether it's a rare disease, how to recognize that question is very, very important. For the patients, to those people who are involved, I think they need to realize that they may be facing nambio. I think that is something that we need to communicate to the patients as well as the civil society as well. Jima-san, do you have any comments regarding that matter? In the research that we have been supporting, we may be using the same developed compound, but maybe we were not able to show superiority. But if we do a late analysis, we were able to show that it was effective in different areas. So early diagnosis is very important, but for undiagnosis, of course, we can go through IRAD. What we need to do before recognizing that it may be a rare disease, nambio, is very, very important. So early diagnosis, we need to come up with a system. Who needs to be involved in that system building? Can you comment on that, please? Yes. Thank you very much. So we have the presentation by Kanagawa Prefecture, and Mr. Osuba mentioned that we need to think about what the nation, the state can do. Of course, what regions can do, different medical institutions can do was discussed. But with Nambio, there are different areas that is covered, and there are many different core hospitals involved in different diseases. And of course, there may be some different therapeutic area core hospitals that is available, and they need to be connected together so that the patients can be involved. And that is a kind of project that is ongoing. Of course, when it comes to work or education, different things need to be involved. So, Nambio Support Center is being established in different regions. And as mentioned earlier, when it comes to pediatric chronic diseases, of course, how we support the patients as well as their parents is going to be very important. We have to come up with a support system so that we be able to provide the consultations. So with the changes in the regulation, I think we need to come up with that kind of a system in which we can provide the appropriate support to capture those needs and to provide the actual support needed to those patients is very, very important. So that is what we'd like to do from a regulatory perspective. Thank you very much for talking about the current situation. Of course, diagnostic lag, early diagnosis, how we reach that point, I think it is very, very important as a theme. Today, we were not able to go deeply into those themes, but I think these themes are something that we need to take on in the future as well. And in the remaining time, we'd like to talk about the second question. So there are many different issues and also outlook for the promotion of a patient promotion and participation when it comes to promotion and decision of Nambio policy. I think this is an organization matter in which we need to work on, and HGPI is working on it. And through this project, I think this is something that we need to continue to discuss. When we look at the Act of Nambio, of course, we have the council, the community council on Nambio measures, and of course, this is incorporated in the Act. What is happening with that council? And from that, are we actually seeing projects or businesses that reflect those voices is something that we need to think about. That is why we have set this theme as a second theme that we want to discuss among these panelists. So can you talk about this regional council for Nambio responses, please? Of course, we have been involved in this council, and every year we do a survey into it. And as of May 1st, there are 157 municipalities in which 60% of the municipalities have set up this council working on Nambio. So 90% of the prefectures have established this council. And of course, 50% of the medium-sized municipalities have set up this council. Of course, the situation of the municipality is different. However, it may be very difficult for them to secure the labor needed, maybe especially after COVID pandemic. But of course, there are many councils who are trying to connect the discussions to the measures. So we need to make sure that coordination is advanced, and that is a revision made in the Act of Nambio. So we need to look at the operation of these councils further to be able to come up with a better way of its operation. So we need to move on different revisions, and we need to make sure that specific measures are looked at. I think this is very important to involve the Act. Next, I want to ask Mr. Otsubo. Mr. Yokota talked about the current situation of the Council, but at JPA, as for the patient participation, I'm sure you're providing support. What are the measures or initiatives that you're taking on to promote it further? What are the changes or transformation that you want to see going forward in this regard? That is my question. So Mr. Yokota just talked about the current situation, but when it comes to the regional council, in order to have more patients participate, I think there are two things that we need to work on. The first, 60% of the municipalities have set this council. In other words, the remaining 40% still have not set up this council. So for such municipalities, I think we need to make sure we take action so they can be promoted,
so that we work together with the Ministry of Health. So as I said earlier, that we sent out our request and appeal documents. So we sent those requests to establish the councils more. And then Tsuji, the standing director, gave the opening remarks today. And then there are the 100-member association, and out of that, there are the 36 the organization working in the different communities. So for the areas they don't have the association, and then those regional council existing are no encouraging those municipalities to appeal to the government to establish their councils. So that's one of the activities. And another one is that although they have the organization already, but they have only once a year meetings. So we saw that the list of participants and that there are many people from the government attending today. So honestly speaking, some organizations do not function well in some regions, although they have the organization itself. So that's the current biggest challenge, I think. So I kind of repeat what I said earlier, but it's our member councils for the Nambyo Association. So we need to gather the information and the current status so that we can communicate that to the Ministry of Health, and then should be reflected in the government policies. And the council is not held very frequently. The reason behind that that's the council having the people of the background, the different occupations, it's very hard for them to get together at the same place on the same day. So we sent that request, and then so for the councils, the administrative staff members can have a meeting, so that we need to start that kind of system, so that some of the administrative staff at least can get together and talk. So that's a request we sent to the Ministry of Health. So it's just started. So in some regions, they rarely have meetings, but now they're beginning to have more meetings. So the regional, the Nambyo Association, talk to the local government and they share their requests and needs, so that we can vitalize the activities of the association work. So, of course, that we share the theme for today's panel discussion to you in advance. And then, so some organizations do not work well, do not function well, and then that's the problem I also noticed. So it's a very good to listen to your opinion for that topic. So of course we have the law and acts, so that the people are working towards creating that organization and councils. But they tend to be satisfied that once they have that kind of organization or the entity, and then so they have that kind of the system already. So that's the next challenge, is that how they can utilize that, how they can continue their activities in the sustainable way. So I'm involved in a project of the different disease area. So, but I also feel that this is a challenge. Of course, that is the people of the government and administration, the local government, Ministry of Health should work harder, but at the same time that citizens and patients also participate, so that there's something that the citizens can do and work harder, but not everyone is dedicated to those activities. So there is a limit, the amount of the time and energy they can spend. But I still believe that the citizens' society should work harder. So because we are doing activities on the viewpoint of the citizens, so that so how we can promote our advocacy activities. So Nishimura-san, do you have any comments? Thank you. So it's the regional council, and then the central government asked them to establish the council. It is very important. And once they establish the council, and then what they can do and what they can evaluate. So what is the criteria for that kind of evaluation assessment of the activities done in each community? So we haven't reached that level. So we just have the one meeting and then that's all, or just send a request once to the Ministry of Health. That's all. So as the Dr. Koketsu mentioned, that you introduced the result of your research, but in what way they can assess, and then how they can get some of the premium points for that activities. So if there's a manual of some kind, and then it will be helpful for the local communities. So we should not be satisfied with the establishment of the organization itself, but we should go to the next step to continue the activities. The participation of the patients and the citizens, but the citizens and the patients' participations are totally different. So we should clearly separate these two. So the participation of the patients are kind of the close discussion. But if we need to have the more citizen participation, all the stakeholders should form the kind of teams and then have the face-to-face talk with citizens. So how we can clarify those differences. For one side, that create a team for the patient participation. So the AMET is promoting PPI, and that's the one driving force. There's no doubt. But PPI becomes a kind of the buzzword. That's what I'm afraid of. So for those people who do the very specific the partnership, and then what you are doing now is called the PPI. So the quite a few research do not know the word PPI. And then as long as they do some kind of the PPI, they tend to think that they can be evaluated highly by AMED. So for those who do the actual work in the good way, and then they should be evaluated adequately. So the PPI should not regarded as the simple buzzword. So the HGPI as well. But the function of the facilitation is very important in this field. Thank you. So once the organization is established, and what's next? So the assessment evaluation is one of them. So that the research done by the doctors like Koketsu-san, and then so you may have the concrete image of that. So any comments? Yes, thank you. So how? So I think about later and how it is linked to the academic work, but what I can say now is the participation of the patients. So what should be done and what is effective? And it is not clear yet. So then I understand the concept, and then I know that we need to act, and then but how can we do? We don't know. I think the majority of the people have that kind of feeling. The patients' participation. What can we do? And that needs the thorough discussion. And then after that, apart from Commons project, in promoting other projects, we start to see the different types of the patient and the citizens' participation. One example is that there are different stakeholders, and then they send out the questionnaire. And then there's one of the approach of the patient and the citizens' participation. So they can approach the wide variety of people, but is it a very deep type of the participation? In the Commons project, we had the continuous discussion for the 3 years. Comparing to that kind of the wide range of questionnaire would be the kind of shallow activities, but not only the deep the activities, because only the limited number of people can be involved. So it's difficult to have the large-scale projects. So when I introduced the Commons project, and then we don't intend to invite the patients to be the representative of the patients, but so by combining the different approaches in a good way, that's important. So the deep level, small number of people can work together. Or on the other hand, that the approach to the big number of people and then get some ideas. So that's one solution.
Thank you very much. So the importance of patient and public participation was talked about. When we think of patient participation, everybody says, oh, that would be too difficult. So they try to raise a hurdle. But of course, it is very important to work on it for the 3-year period. But if they can participate from a very near method, closely, I think that would be very important so that they would not inhibit participation by the patient and the public. So patient participation, public participation is something that we also need to think about in order to promote it further. When we planned the symposium, We said that, of course, each of the topics need more than 1 hour for discussion, but today we have commemorated the the enactment of Nambyo Act for 10 years, and also the discussion was held, and also presentations were made about what we need to think about when it comes to Nambyo policies. There are many more questions I want to ask, but it is time, so we'd like to close the symposium for now. To the speakers and to the participants, I'd like to take this opportunity to thank you once again for your participation. Thank you.